Good morning, friends. Welcome to a new topic, Riddles in Medicine. And today I am going to talk about incomplete history taking. This was the incidence of late 1970s when I myself was the president of one of the oldest Lions Clubs of Delhi, Lions Club Delhi West. We used to have meetings of President Forum, and one president from another Lions Club approached me about his son-in-law. His son-in-law was a principal in a school. This was a Sindhi family. The patient complained of retrosternal pain, that is pain behind the breastbone. It was constricting in nature. There was no sweating, no radiation of pain, and no faintness or giddiness. The patient was non-diabetic, non-smoker, moderately active. I did his ECG, which showed borderline changes. I also took blood for the enzymes which were available at that time, but all turned out to be negative. So I did not find any evidence of myocardial infarction. I would say unequivocal evidence of myocardial infarction. But the patient had a problem. He kept improving for 3 days. On 4th day, he had massive bleeding from the rectal region. He then disclosed that he had piles. This massive bleeding resulted in decomposition of the coronary supply, and he developed myocardial infarction, what we call as a heart attack. He was now admitted in a private hospital where he died because of myocardial infarction. What happened, friends? A patient who was non-smoker had just hypertension. Why he died? Here you are to understand that what is myocardial infarction, why it occurs. There are many names given to this disease. One is CAD. You are all familiar, doctors writing CAD, which means coronary artery disease. Some people write it IHD, which means ischemic heart disease. Some write that it is a myocardial infarction. The other is recorded acute coronary syndrome. Some write angina pectoris. Some write unstable angina. There are a number of things which little variation up and down. Basically, there is a block in the coronary arteries. That is what we say the underlying disease. There is an underlying disease. Then there are some contributory factors which increase the disease. Then there are predisposing factors which make the patient more prone to get this type of disease. And finally, there are precipitating factors which are the cause of immediate heart attack. Like, for example, cigarette smoking, eating meals, physical exertion. These are all precipitating factors. I give you an example. You take your meals, and in a false impression to digest your food, you start walking, having a stroll. And those who are used to smoking, they would light a cigarette and smoke. Now look at it. Your physical exertion, that is walking, puts pressure on your heart because it makes the heart work more. Your cigarette smoking, nicotine directly causes constriction of the coronary arteries, as well as smoking causes tachycardia, and all these things again cause strain on the heart. Your eating results in digestion of your foods. More blood goes towards the intestinal tract for absorption of the food, and less blood goes to the heart. So all these factors put together put a lot of strain on the heart, and if the heart is already vulnerable, the patient is bound to have a heart attack. So having known these things, in case of our patient, massive bleeding from the piles acted as a precipitating factor. Our patients usually do not like to talk about urogenital problems. In one case where I was given a case for examination, short examination of the abdomen, I was asked 3 questions to which my answer was no. That was, have you done PR examination? PR examination means per rectal examination. My answer was no. Have you done the PV, per vaginal examination? Answer was again no. Why? Because the patient was female. Then I was asked, have you examined the genitals? Again the examination answer was no. The reason being that I was a male and the patient was a female. From the medical point of view, there is nothing like male and female. But from the social point of view, this is a very important thing and taboo on us. I was young, I could not take this type of courage of asking the female patient to expose and get into any problem. The examiner was not bothered about it. He simply wanted what the book says, and books clearly say that in the case of abdomen, you have to mention hernial sites, you have to mention genitals, you have to do the PR examination, and you have to do the PV examination. So friends, these are the difficulties, they create a problem. Now in history taking, it was incomplete history taking because I did not know he had piles, so therefore I did not ask him. He did not volunteer the history that he has piles. If he would have volunteered this history, probably he would have got something better. Now I again show you the diagrams which I have shown you. Some of them I have shown you before also. See this diagram, you have seen it before. I am bringing it close to so that you can visualize it properly, and you can also later on make a note of it. Now see what is this. Just to revise you quickly, this is the right ventricle, you know it very well. This is the left ventricle. This is the right atrium. This is superior vena cava, SVC, bringing blood from the head and upper limbs, and this is the inferior vena cava, bringing blood back to heart from the lower limbs and abdomen. All this blood is unpurified blood or unoxygenated blood. This comes to the right atrium. From right atrium, through the opening, this goes to the right ventricle. From the right ventricle, through this artery, it goes to the pulmonary artery to both lungs like this, and from after purification through the pulmonary veins like this. This comes back to the left atrium. From left atrium, through this opening, it enters to the left ventricle, and from the left ventricle, it enters the big channel, that is aorta. This goes behind the pulmonary artery. That is why you don't see it here in continuity. I have shown you here this portion and then this portion, because this portion is behind this, covered by this artery. This artery is on the front, aorta is on the back. Then this goes up, and then it is called ascending aorta. Then it takes a turn, it makes an arch. It is called aortic arch. And after the aortic arch, this goes behind the heart like this, and then comes out as the abdominal aorta. Now see what you know about the coronary arteries. See another diagram. I am first bringing it close to you so that you can make notes later on from this. You can stop the video at this place and make note. And now if I tell you that there are 3 coronary arteries, how these 3 coronary arteries? Now see this is this channel, this is the aorta, This is aorta, which I showed you from the arising from the left ventricle, and from this artery, this is going like this. This is the called right coronary artery, and from the aorta, the other side of the aorta, which is behind this artery, this is pulmonary artery. Behind the pulmonary artery arises the other artery, which is called the left coronary artery. This was the see here I have shown. This is the left coronary artery, which divides at this place into one branch like this. This is left anterior descending artery, and the one branch which is going like this. This goes around the heart like this. This is the left circumflex artery. So you have right coronary artery from the aorta, left main coronary artery from the aorta, then dividing into left anterior descending artery, and then the left circumflex artery. Please concentrate on this to understand the right coronary artery, then the left coronary artery arising from this, and then dividing into two, left anterior descending coronary artery and left circumflex artery. Now these are the three arteries which supply the muscle of the heart, that is the myocardium. If there is a block in any of these three arteries, that is what we call as a coronary artery disease. Then if there is a block in one artery, we say it is single vessel disease. If there is a block in the two arteries, we say double vessel disease or two vessel disease. And if there is a block in all the three arteries, this is a triple vessel disease. Now, if there is a block in the left main coronary artery, it is not equivalent to the two artery block, because it is divided into two. So if there is a block in this artery and block in this artery, or block here, it should mean same thing, but it is not the same thing. The left main coronary artery disease is a very severe disease. It has to be treated in a different way than the two artery disease. Therefore, if there is a disease of all the three arteries or left main disease, the answer is straightforward. A bypass surgery should be done immediately, because patient can suddenly die. Now see another diagram of the heart, again very close to you. To see the things, you can stop the video and again watch it very closely. Now what do you see? You see here, this is the aorta. You see this is the aorta, okay? And you see this is the pulmonary artery, dividing into left and right both ways, and you find this artery coming from the aorta. This artery is the right coronary artery, and this artery which is coming behind the pulmonary artery, this is the left main coronary artery, dividing into, this is left anterior descending, and this is the left circumflex artery. This is left circumflex. Again see, this is left circumflex, this is left anterior descending artery, okay? And these gives on branches. These branches pierce through the heart muscle and supply the heart muscle, and then go inside, supplying the lining membrane of the heart. The lining membrane of the heart is called endocardium, and the outside lining is called epicardium. So from epicardium to endocardium, that is how the blood spreads. You see the blood, these arteries, they arise outside the heart from the aorta, run on the epicardial surface, and then at times pierce through the muscle of the heart to supply the heart muscles. Now it is easy to understand, when the heart contracts, that means it squeezes, all the arteries which are passing through the muscle will get squeezed, no blood will flow in them. But when the heart relaxes, then these arteries open and blood goes into them. So remember, coronary artery filling occurs only during diastole. During systole, nothing goes in them. Many times patients come to us and they say their blood pressure is low. Many ask, what about the lower blood pressure? You frequently see patients with hypertension who are on medicines. Their lower blood pressure is 60, 50, in that range. And patient is always worried, sir, my lower blood pressure is very low. Now they have to understand that the function of lower blood pressure is to fill the coronary arteries, and for that you require a pressure of about 10 to 12 millimeter of mercury. So if your pressure is even 40 millimeter of mercury, you don't have to worry about the lower blood pressure. What you have to worry is about the upper blood pressure, and that is called systolic blood pressure, and that increases your chances of heart attack, your heart failure, your stroke, kidney failure. All these are raised by the this upper blood pressure. So friends, this is a very important thing. I told you that history taking must be complete. We must encourage the patient to come up with everything which they think relevant or which they think is not relevant. Even then, they should tell. Let the doctor interpret and find out whatever is the thing. So friends, now I leave it to you with the request, please do subscribe and comment. I do not say like only, I say comment, because commenting tells me that who is interested, who is watching it, or at least who has opened my video. If you do not comment, even if you have seen it, I do not know about it. Thank you very much. Next time I will take up another case. Thank you.